Tear duct obstruction, or the fancy word nasolacrimal duct obstruction. This can happen when we're infants, and it can happen when we're adults. In adults, it's typically caused by infection, inflammation, neoplasms, or trauma and stuff like that. And in infants, we have this valve called the valve of Hassiter, I believe it was called. It prevents the reflux of air from our nasal cavity going up backwards to our eye. And it typically opens up within the first couple weeks of life, but before we start producing tears. But in some newborns it doesn't, and the backup of tears can lead to secondary infections and things like that are more worrisome. Now, some predisposing factors of tear duct obstruction or the nasolacrimal obstruction are chronic allergies, sinusitis, surgeries, fractures, radiation therapy. And we have to know that some basic symptoms of this obstruction are tearing, ocular discharge, and eyelash crusting. Now, the reason why we point out further symptoms like fluctuant erythema and tenderness, because this could be suggestive of something called dacryo or dacryocystitis, and this looks like this, okay? Very different from just crusting of the eyelids. So we want to rule that out, and we'll be able to see, whether it's small or large. We want to check for that tenderness, that erythema. Now, in congenital, when we're infants, this nasolacrimal obstruction should resolve within a year, and observation is usually recommended for this. Now, the cricklor massage, which is just a massage of that inner canthus there, can be performed to kind of help clear up to even half of these sooner than later. Now, in those with suspected dacryocystitis, the initial treatment is warm compresses and, again, massage of that medial punctum. And topical antibiotic eye drops may be used prophylactically if we suspect an infection, a bacterial infection. And oral antibiotics are usually reserved for those with systemic symptoms. And it's not abnormal if we were to obtain cultures of the exudates, especially if we suspect any systemic involvement. Some antibiotic options would be trimethoprim and polymyxin, tobramycin, ciprofloxacin, or ofloxacin. And these are eye drops that are done every 6 hours, 4 times a day usually, for a short course of about 3 to 5 days. And after, if all these treatments have been tried and nothing happens, over 6 to 7 months, we'll say we'll usually at least give it that for just the regular nasolacrimal duct obstruction. Then we can refer to an ophthalmologist at that time. But if there's something like that we might think is systemic, or like a dacryocystitis that we don't really feel comfortable managing, then we'll also refer to an ophthalmologist in that point as well.